beating heart models, so we can even see the heart in action, so that we can even test the effects when the heart is moving. So it's quite impressive where we are heading towards. So in conclusion, minimally invasive cardiac surgery is extremely safe option that is no longer the future, but we can consider absolutely the present. It's expanding the number of applications in cardiac surgery. It requires the development of specific expertise in some techniques like valve repairs. That's why we really need to improve the learning opportunities, and translational research, cooperation with teams like Terry's one, are key to facilitate training. So again, thank you for the great opportunity.
Okay, well, that's a bit of a hard act to follow. Thank you very much, John, and the Italian Cultural Institute for inviting me to come here and John's talk about interventional minimally invasive cardiac work. So I'm going to give you a bit of a snapshot of how we ended up talking together and starting to move in the same direction. I come from the Robarts Research Institute, where I've been running a lab dealing with minimally invasive surgical interventions for quite a number of years now. A whole variety of different sorts of procedures, from the brain to the heart to the liver to kidneys to spine. But they all use a very similar platform technology with imaging, ultrasound, virtual and augmented reality. And so I'll talk about how we got interested in imaging for cardiac valve repair and replacement. I won't go over this. John has already talked about some of these different repairs. And most of these repairs are done with the surgeon operating on the valve directly. But there are some also that access the valve through the vascular system of the patient, or directly through the wall of the heart by placing an instrument through a tiny incision between the ribs and then going straight through the wall of the heart and the apex, as we see here. So these procedures, both the transvascular approaches and the transapical approaches, can be used for both the repair and replacement of the aortic valve or the mitral valve. In the mitral valve, one of the repairs is clipping the leaflets together. Another repair, which I'll talk a bit more about, is replacing these cords that sometimes break. And this is what this instrument is doing. So our surgeons were interested in these approaches. And just to give you an example of what sort of imaging is used for some of these approaches, on the left you see the fluoroscopy image that's been used to guide a transcatheter aortic valve replacement. You can see the valve, the stent here, is finally in its resting place. You can only tell that it's in the right place because for a couple of seconds you see this blush of contrast showing up the aorta, and that defines where the root is. This is ultrasound that's obtained from a transducer inside the esophagus, looking up at the heart from behind. And you can see it's very, very difficult to tell what's going on in either of these images. And sometimes things go really, really wrong. Here's an example of the catheter, the valve being placed with a balloon catheter. It's being expanded by a balloon, and hopefully it's in the right place. It will stay there, being held on by some of the calcification that's in the valve root. But you can see just at the last part of the video it started to slip, and that's definitely not supposed to happen. And a few minutes later you can see it bouncing around inside the patient's left ventricle. They're both in the fluoroscopic image and in the ultrasound image. Fortunately, the surgeon could go in through the wall of the heart with a pair of tweezers, scrunch this stent up, pull it back out, and the patient survived. But it's not something you really want to happen in your operating room. So this told us that there were huge problems in the way we image these procedures, how we're guided by images for these procedures. And why do these problems occur? Well, you can see a surgeon over here, he's looking at a screen, you can look at where he's gazing. He's manipulating some sort of instrument. It might be a catheter, or it might be an individual rod-like instrument that's going through the patient's chest into the heart. But there's no coordination between what he's seeing and what he's doing. So he's looking one place, he's manipulating somewhere else. He's trying to manipulate an instrument. He wants it to move in a certain direction, but he has no idea relative to what he's seeing in the image, what the instrument is doing. So he can see the instrument, but he doesn't know what he needs to do to move it, or what he needs to do to move it to where he wants it to move. And so this is both a result of poor visualization and poor hand-eye coordination. So our surgeons came to me and my colleagues and said, we've got a problem. Can you help us out? They said they wanted to see a fully three-dimensional version of the beating heart, made from the pre-op MR images from the patient, fused with ultrasound in the operating room, have all this in 3D. That would solve their problems. So we had a couple of PhD students working on this, and we built a system that showed the beating heart with its chambers and the ultrasound, and the surgeons were in the operating room with their 3D stereo glasses on. And we said, well, do you like this? And they said, well, there's so much information in this image, I really can't tell what I'm doing. And a cardiac surgeon in the middle of a life-saving operation doesn't want to have his cognitive load exceeded. You need to keep things simple. So we went back to the drawing board and tried to figure out exactly what we needed to do and what we needed to show the surgeons. We chose this particular procedure, which is the one that replaces the cords in the mitral valve that are responsible for stopping the leaflets from opening up fully. If the cords are in place, the valves close like this. If one of the cords breaks, this one valve can flip out, and that can cause the blood to push back out in the wrong direction. This is the sort of imaging that they had. This is the ultrasound image made from the transesophageal echo image. And this is the standard of care for getting this probe through the heart, through the chest wall, through the heart wall, and into the right place here. We put a tracking system on the tip of that instrument, and we tracked 5 different surgeons where that instrument went, from the apex of the heart down here, all the way up to where it needed to be in the middle of this green circle, which defines where the mitral valve annulus is. And with the 5 different surgeons, each surgeon represented by a different color, it was just a total mess. Just like Italian spaghetti. So clearly this is not the right way to do it. So we came up with a system of being able to tell a computer where the probe is, where this instrument is, where the ultrasound transducer is, and to give them the surgeons a display that looked like this. This showed the ultrasound beams. These two images are actually 90 degrees from each other. So we redrew them in their appropriate relationship. We gave them a display that showed both how far away they are from the target and how far off center they are from the target. And we let the same 5 surgeons do the same procedure again, track their instrument, and we got a result. This is what it looks like in minutes of practice. We got a result that looks like this. Straight in. So instead of being this bowl of spaghetti, we've got 3 straight lines. And this was 4 times faster, 40 times safer in terms of the tip of the probe going to places within the heart that it shouldn't have been going. And it was responsible for restoring the hand-eye coordination of the surgeon. And this is really the key point. We designed a system that was easy to use and didn't require any reading of manuals. These surgeons literally came in to the operating room, saw the device, saw the display that they had to use, and went right to it. They didn't have to be taught anything. It was totally intuitive. It was like picking up your iPhone and trying out a new app. Trying to get the company that we were collaborating with to adopt it was another story for another day, but that's the project that sort of started our journey to building the sorts of valves that Dr. Bisleri was talking about. So this is what the surgeons are looking at in the operating room. 2 surgeons, an anaesthetist, looking at this image. The pig model is down here. When you're building a device like this, you need to constantly test it. And the only way we had of testing these systems were live animal models. Which animal? Well, we used the pig, because the pig heart is the closest to the human heart, but it's not the human heart. They're very expensive. They require dedicated animal operating room facilities, which we had access to in London. But we required a large staff component. We had to jump through all sorts of regulations relating to animal surgery, transport of animals, disposal of animals. And the animals themselves, they're fantastic to work on and train on, but they go into atrial fibrillation spontaneously occasionally, and so this is not good. I'm getting ahead of myself here. And sometimes you just start the procedure and the animal dies. And in addition to all of that, the pig heart valves are not the same as the human heart valves. They don't have the same diseases, and so we can't look at the same pathologies that we would expect to see in humans. So we had to find a better way. And the better way was to build this heart valve simulator, this cardiac simulator, which you can see this left ventricle that is contracting, pulsing a blood mimicking fluid through these artificial valves that are placed inside that chamber. You can see the display up here when we're performing a procedure that's entering the heart through the apex of the heart. So this cardiac simulator has undergone a few iterations. We're currently done with this one now. About the time, somewhere between version 1 and version 2, we started up a company to sell these systems, and mostly big imaging companies and a number of medical device manufacturers bought these systems to test out their procedures. This system can very accurately reproduce the dynamics of the heart valves that we would see in a normal patient. It can reproduce the important pressure differentials that we see on one side of the valve and the other side of the valve. We can control the heart rate. We can give it very realistic heart beating patterns. We can measure the flow rate. We can adjust the tension of the cords that are holding the valve leaflets in place. So it's a very elegant way of putting an artificial valve in a very, very controlled environment. And the important thing here is that we can put patient-specific valves into this. So how do we get patient-specific valves? Well, fortunately, the ultrasound images that we use, that the surgeons and the anaesthetists use, look like this. This is a 3-dimensional transesophageal echo image, or 3D ultrasound image of the heart valve in particular. And we can feed that heart valve model into a computer program that allows us to segment exactly where those leaflets are. You can see as the operator is modifying the position where these leaflets are segmented, we're getting this three-dimensional valve building up on the side. Once we're satisfied that this is the appropriate shape of the valve, we then send it to a 3D printer, and it prints a mold. And then we paint silicone onto that mold very delicately, and at the same time we attach these threads that act as the cords, the neocords that or chordae tendonae that hold the valve leaflets in place. Then we can validate the model in this cardiac simulator. You see there, so you can see that we've now placed an ultrasound transducer looking at the artificial valve, and we can now compare that image with the artificial valve with the image that we saw in the patient prior to us taking the patient's image and making that artificial valve. And if the images are the same, we can tell that that artificial valve is going to faithfully replicate the functionality of that patient's valve. Then we go in, we can put this into the device that John showed earlier and start to do surgical repair and validation on this. Here's what the simulator looks like from various views. We have a camera in the simulator that can show us exactly what's going on with the valve. We've got pressure sensors that can show us the different pressures as we change the dynamics of the flow by changing these tension in these cords. And we can also look at the three-dimensional transesophageal echo, the three-dimensional ultrasound. So we've done a very good job of replacing the need for live animal studies. And we literally haven't done an animal study in 15 years now since we've had this technology available to us. Just another example of what we can see with the 3D ultrasound. And the 3D ultrasound image doesn't just give us the anatomical image, it gives us flow. You've all heard of Doppler, you've heard of a Doppler signal when you're standing on the street and the fire truck goes by, the frequency increases and then it decreases. Same thing with ultrasound being reflected from particles in the blood. And it can, the Doppler ultrasound system can tell whether the blood's flowing towards you or flowing away. If it's flowing towards you, it looks red. If it's flowing away, it looks blue. So this Doppler signature can tell the surgeon an awful lot about how the blood is behaving in this repaired valve. So we have an environment where we have start off with a surgical procedure that takes some preoperative imaging data that creates a surgical model. We put the surgical model in the simulator. We can compare the Doppler with the Doppler from the patient prior to surgery. We can practice the repairing of the valve model. And the surgeon will go into surgery and perform the surgery. We can then compare his post-repair data with the data that we get out of the simulator. And this led to a study where we allowed the surgeon to look at different repair techniques to see which one was best suited for that individual patient. Because as we said before, all patients are different and one size does not fit all. And so just as an example, this is a surgeon, doesn't go quite that fast in practice, of course, but this is a surgeon practicing a procedure on the basis of one of these artificial valves. And there we see the Doppler, the red and blue plumes from the Doppler signals. So how well does this approach work? Well, with this fairly small study we did, we matched the respective pre-repair model with the patient's pathology, and The models underwent successful repair simulations, and we demonstrated that this was really a very effective way of rehearsing procedures before surgery. Another example of the ultrasound image of a model prior to surgery. Let me see if that has a... And then two different versions of a particular procedure, looking at the ultrasound image with one of these rings that's been placed on, and these new chordae tendonae have been attached to the valve leaflets, and a slightly different variation where the ring has been put in, but also there's been some resection performed as well. And we can look at the different performances of these three different, or these two repair strategies compared with the preoperative model. So I think we've really demonstrated the value of realistic heart valves is both in the ability to do patient-specific surgical rehearsals, allowing us to choose the best procedure that's optimal for that particular patient, and also in the training arena where we can avoid the use of animals and cadavers. We can very easily replicate different disease states. We can either take valves that have been made from patient images from patients that have these different disease states, or we can actually build mathematical models of each of these disease states and build different sorts of valves with different disease characteristics just from the mathematical formula that's describing these valves. And so this provides a standard training environment for surgeons. And through a stroke of luck about 3 years ago, one of my undergraduate students inadvertently introduced me to Dr. Bisleri, and we've had this fantastic relationship ever since. And we now are joint owners of a company that's marketing these devices. And this device, as you heard, is called Carmosum. Basically that's it. So none of this, just as John said, it's all teamwork. None of this happens in isolation. We have a fantastic team. We had a huge number of people locally and a lot of external collaborators in the UK and the US. And of course, we've relied on a tremendous amount of funding from a whole range of different Canadian funding agencies. So thank you very much for listening.
Thank you. This was very interesting and two very, very rich presentations. So I will invite now Dr. Emilia Luca and my two speakers to join us for a moderated Q&A. Thank you. The only thing is, we don't have the resources of the hospital, so we don't have microphones and what we call gelato microphones, ice microphones, especially cordless. So I will unfortunately ask my speakers to project.
Yes.
So I would like to open the floor to questions from the public first, and after maybe I can start.
I have a question for you, doctor. And you mentioned that one of the procedures, the one that you do here in St. Mike's, is not well practiced in the U.S. Now, why is that? Why is the reasoning? Is it just...
Canada.
Yeah. I thought it was in the U.S. they were not doing it.
No, I mean it is more diffuse in probably is the one you mentioned, one about the interfibrillation, the ablation, or do you mean like the mitral valve repair? There was a small
The repair.
Yeah.
Yeah.
Well, the problem is that historically, initially, the surgeons used to replace valves rather than repair valves, and when scientific studies demonstrated that repair is better than replacement, still there is a lag between that scientific evidence and a tendency, which is changing in the past few years, The problem is that you are dispersing in many people doing few cases. And if you think about, first of all, the landscape in the US is very different than in Canada, where we have less centers. So everything tends to be a bit more focused, going into being referred to certain centers. But in US, very often you have centers that perform like 200 surgeries a year, not Michael's in general. If you think that in Canada on average is more around 1,800 to 1,000. So, and as a, thank you, as a consequence, when you go into the niche of the valve problem, then you just have surgeons who may just do these valve repairs, which are not very effective and reproducible. That's why there has been a strong advocacy in trying to change that and make sure that people tend to focus on certain practices. Clearly I could not be doing everything. Like my practice is mostly doing mitral valve repairs, so even my colleagues, when they get a patient, they refer to me. But that's how you can get to excellence. And similarly, there are areas which I'm doing less and some other colleagues are focusing. So we can get better at it.
Thank you. Any other question? Yes.
Hi, a lot of elderly people are diagnosed with heart failure. Would they be candidates for this procedure?
So, well, heart failure is just a consequence. Yeah, it's a consequence of something that is not right. There could be too many different causes. It could be valve disease. It could be sometimes presence of blockages in the arteries of the heart. Sometimes there is not a specific reason, but still you develop heart failure. We really have a series of tools that goes from medications. I'm very much involved also in using catheter-based procedures where we don't even do these less invasive surgeries. It's really non-surgical because we go in with the catheter. So I think that my answer is we have probably now more and more tools to address in a tailored fashion. And one of the things I'm very excited and proud of is that where I'm working today, I've got access to all the different technologies. So rather than just having one hammer all the time and just seeing everything as a nail, I can kind of tailor. So when a patient comes, and sometimes it's just medications, the best thing for patients, sometimes catheter based, sometimes minimally invasive surgical.
Thank you.
So when you talked about like MIS and like the adoption of it, it's a lot of work with like the nurses, anesthesia, everything like that. So are you able to speak to what you achieved in cardiac to make it relevant to like minimally invasive knee surgery, hip, spine, like a lot of other divisions? Just because it seems like you have really good research behind it.
Well, I got to say that first of all, I got to be thankful to my colleagues because of course you can come in and have a vision, but at the end, the analogy I often make, this is not like a tennis game, this is more like a basketball or Formula One actually, where we have the luxury of sitting in the driver's seat, but if somebody, when you're going for a pit stop, is not as coordinated as yourself, you're never going to win the race. So I think it comes down to probably trying, starting with building the team and trying to make everybody excited and involved into this vision. Because I mean, at some point then you get also your self-feedback. Like I keep saying, I've been doing this for a fair amount of years at different stages, of course, resident and stuff, but like to maybe 20 years. But when I came to St. Michael's, my colleagues who never did it came up with solutions that I never thought about. So you always learn, so you never end.
Dr. Ray would like to add something.
Let me just add to that. From my perspective, I think the answer is definitely yes, because a lot of the minimally invasive procedures that we've been working on, although they're treating different clinical symptoms, they use a range of very similar platform technologies, like devices that track instruments in space, devices that can visualize images. We use a lot of virtual and augmented reality as part of the interface between the surgeon and the patient. So we have in fact used the same sort of technologies on all of these different diseases, and I showed you, my very first slide showed you all the different areas that I've been working on. They're all similar in the fact that they use very similar platform technologies. And we also learned a very important lesson in minimally invasive procedures when you're using images to guide you. An image-guided procedure is very much like using a GPS to get to your home, to the parking lot of a hospital, for example. But the same GPS can't guide you into the very, very tight parking space. You maybe need a different imaging procedure. And so we've really exploited that to optimize the procedure to use one sort of imaging to navigate to where you need to be, and a different sort of imaging to position your instrument right on the target. One of my very close cardiac surgeon colleagues, Dr. Gerard Guéridon, who I'm sure John knows very well, I worked with him for over 20 years, and he would say that surgery is a side effect of therapy. It's not the therapy that causes the post-surgical trauma to the patient, it's the act of getting to that target. Hence the move towards minimally invasive or non-invasive surgical and therapeutic procedures. The heart-lung machine that's often necessary in many of these procedures is one of the most traumatic parts of the procedure for the patient to withstand.
I have a question. Paul, you want to add something?
Yeah, I also want to say that one other aspect that goes back to what Terry was mentioning is I think cross-pollination of different fields, because I think that personally, just purely surgical, when I've been in other ORs, not cardiac surgical, and I've seen things that I've never thought like maybe could not directly be applicable to what I do, but somehow the principle, that's amazing. And one thing that I find similarly extremely refreshing is that when you think you're pretty smart as a cardiac surgeon, then you meet with a bunch, maybe not even a very senior engineer, but like students, and in a few days they come up, yeah, we found this solution to your problem. It's like, okay. So, but it's actually great to see sometimes thinking outside of the box, because I guess to the point Gary was making, that there are some constant elements that recur, and that's why also this translational work, which I thought was very interesting as a discussion for the evening, is that it's not just what you do in your own little field, but try to bring a different perspective is very helpful to advance.
I have a question for both of you. So the first is, the first question, actually I have a couple, is you said that this procedure is for everyone basically, unless, you know, of course you stratify patients from pro and cons, but the question is, any kids has been used this procedure, and if it was successful, and if you modulate the valve, and if you can add some things about not just adult getting this procedure done?
Well, I can say that specifically, like the pathologies I showed you about are not typically seen in kids, so it's more for adult patients. However, there is absolutely also minimally invasive pediatric cardiac surgery. And one thing I'm actually very proud of, talking about like collaboration, we have, I also have a very close cooperation with some cardiac surgeon colleagues at Sick Kids. So when I get some adult patients who discover a congenital disease late in their life, they obviously don't go to Sick Kids, they come to me, but I actually do the operation together with my colleagues from Sick Kids who are obviously having an expertise in congenital diseases. And similarly, these colleagues are coming to see how I do certain things, because they are potentially planning about translating that into their pediatric population, which obviously has also some other technical challenges, because when I talk about heart-lung machine, we have tubing that if you're using in a kid has to be miniaturized compared to...
Yeah, for this reason I was asking.
Yeah.
Do you want to add something?
Sure, and we also have been involved in with both the Italiano Hospital in London, UK, and the CHOP, the Children's Hospital of Philadelphia, in using the techniques that my student Patrick had developed for building these these patient-specific valves, specifically for young kids with congenital heart defects, because each one is really, really individual and they need a lot of planning to be able to repair them. So, yeah, I think we've made impacts on kids as well as adults.
First,
Yeah, I have a question. A couple of years ago, I was a very good candidate to have my knee replaced. I chose not to. I wasn't able to play soccer again, but my quality of life is not so bad. And recently at my doctor's visit, well-known doctor, we talked about this and he said, you made the right move not to replace it. Based on current information that has been provided. He was one that had his knee replaced. He was an athlete of some sort. So just wanted to get a little more enlightenment of this procedure. Is it still one that they encourage? It almost seems like a factory where they're anxious to get these things done as many as possible. And I'm not sure if that is the best solution.
I'm really not the right person to answer that question, but I do know that some of my colleagues are working on non-surgical techniques to repair knees that would otherwise be replaced, and they've got techniques for strengthening muscles and building up the musculature around the knee. So yeah, I think there is a trend towards more conservative measures for a lot of these problems, although I have to say that I have a number of friends from New Zealand. I'm a Kiwi, and I have all my friends in New Zealand do a lot of hiking, and they've all had their knees replaced. So I'm not sure what the role of conservative management would have been with them, but I do know that there's a trend in that direction.
And
There
one
was
last
another-
question,
yes,
sorry.
for sure.
In relation to all the doctors in Canada, what percentage of them are aware of these products that are out there for them?
Well, regarding the orthopedics was not my favorite topic in medical school, so, but I can say that the answer I would give you, Tony, is that the work we're doing, like on repairing valves, goes a little bit into exactly the idea that rather than randomly going and replacing parts of the body, that could be a knee, that could be a heart valve, we should try other solutions to avoid that, because there could be consequences for the long-term effects of having just a valve or any prosthetic material that may malfunction over time. And in terms of the new techniques, like I gotta say that there is obviously an issue of training people, and that's why they are not widely available. And sometimes I think it's also important that patients start demanding for things, because I think it's a huge drive. I gotta say that I'm seeing, since I came to Toronto, that there is now growing interest in other centers to potentially start doing the minimally invasive procedures. It's not going to be an easy journey, but it's very welcome because patients need that. But I've also seen that when patients ask for that and they don't get it, then surgeons eventually call me saying, well, I asked for it, I'm not doing, can you then please do the procedure? So I think that will eventually drive surgeons to change their practice because they also want to be able to offer that. So it's an incentive. So sometimes part is education and part is something that people don't want to talk about, but I think it's positive, which is competition. Competition is positive because you need to step up your game if you want to stay in the game, and that's why I actually welcome, because I'm sure if I have other colleagues doing this, I will go for the next challenge and I'll get even better at doing the things I'm doing. So
There was a question at the back first, sorry.
Wonderful, thank you. I was just interested in hearing a little bit about artificial intelligence, robotics, like the Da Vinci 3. You talked a lot about hand-eye coordination, and I know there are surgeries that you do in the other room, and soon you'll be able to do them in other cities. And I'm just wondering how you see the future and how that happens so that you can have quality healthcare that you can transport to people that can't be in the room with you, or having to transport somebody by helicopter, as opposed to using robotics, and some thoughts about that in the future.
Sure. Interestingly, the Da Vinci robot was initially designed to do heart surgery. So 25 years ago, the first Da Vinci robots were doing heart surgery. That somehow fell out of favor in favor of prostate surgery and other abdominal surgeries. In London, we're still using the Da Vinci for some procedures. Don't know if you are in St. Mike's?
No, not yet.
Okay. So yeah, there is a potential. I mean, it was really overhyped in the early stages. It wasn't as successful as it perhaps could have been, and I think some of these more these minimally invasive procedures that still have the human much more in the loop than sitting in another room and basically driving a robot. There certainly is a value for having a robotic system at a remote location, but there is the question of the time it takes a signal to get from the surgeon's hands to the robot and back again. If that's more than about 1/10 of a second, then things start getting out of sync and it's not very successful. So there is a move towards autonomous robots where the surgeon isn't in the room at all, isn't in the loop at all. I'm a big skeptic about autonomous surgical robots, and I'd like to hear John's comment on that.
So, well, thanks, Bob. It's a very good question. So I would say that I've been actually trained on using the Da Vinci, and I think it's an important tool, but I don't think we have to see as the goal. It's a tool towards the goal of doing more precise and more refined surgery. As Terry mentioned, there are some technical challenges when, for example, you do heart surgery, because you need to do several things that require basically a strong presence, not just for the person that is moving the robot, which is not directly scrubbed, but is sitting just nearby, but you also need somebody on the table that is going to be your assistant, that is coordinating, doing things also together with you. So it requires an infrastructure that you have to build from this standpoint. Interestingly, Intuitive, the company that developed the Da Vinci, is continuing to scale back from cardiac surgery, which we don't understand why, but as much as now there is always an interest in trying to keep that up, in favor of, I don't want to call simpler, but more straightforward procedures, as Terry mentioned, like prostate and other kind of surgeries. There are other companies who are coming on the market with robots, and I think they will probably, hopefully, a more progressive introduction of robotic platforms that can help enhancing what we're doing. In terms of AI, I think it's very important, because obviously in the planning is key. I think that some sort of, as Terry was mentioning, we don't want to be overloaded with information with surgery, but having some additional information during the surgery that can help complement, I think it's key. Giving some, additional info. Speaking about AI, when we're talking, for example, about the simulator you saw, we're actually working on some versions where you're gonna wear like glasses or a helmet where you can basically see an image which will look like you are in the operating room, but in reality you're working on a physical model which doesn't really look like the real one. So we are really going into that direction, and even the option of getting feedback. If a person is practicing, that the AI can basically say, well, you're not doing the stitch right. Here you have the risk of creating this injury or the other. So things are coming along progressively. We're not there yet, and I hope that, just to be realistic, as a physician, our healthcare system has to find other ways to basically allow this to happen, because right now, we're just with a very old-fashioned model that just says spend less money, but that's not going to consider the journey of the patient. And maybe sometimes you spend a bit more upfront, but you have so much advantages down the line.
There was another question, I guess, in this area or no? so I can move forward. I have a question to Luigi. Would you like to comment or add some things to the young public in the room and also the younger generation of future MD or PhD, that how this process that leads you to invent this lady tool and how difficult it is to go and finalize what your idea was in your mind and after a concrete tool that can benefit the population.
No, thank you. I think it was a very enlightening experience. So I would say in general, if you go into anything that is a medical device or a medical therapy, you're obviously going to face issues in terms of regulations. My probably immediate recommendation is that do not think that just because it's a good idea, it's going to work in terms of commercializing the idea. Because the problem is that we can all come up with brilliant ideas, but the cost of R&D, so the research and development, and the cost then to manufacture and sell a product is going to be unsustainable. And for example, who's going to pay for that? Like, let's say that you even find a way to develop that. Maybe you won't find a healthcare system, not even in the US, to pay for it. So it's an interesting perspective because even myself, I get approached many times by surgeons who are just telling me, oh, I got this brilliant idea, and I'm like, yeah, you have no idea how many ideas I have, and most of the time it's just like 1 of 100 that it may be actually feasible. So you got to face a slightly different perspective, which is not just your own idea. And I was lucky that my idea was fairly simple to be realized. So that was a pure serendipity, and the company had a strong interest in going into that direction. And then you need to be persistent, because you're gonna find many doors that are closed, and you eventually have to keep, pitching your idea, so learning how to do that, and eventually you will find a potential. If it's really valuable, you're gonna find somebody who's gonna be realizing that. So I think be realistic of seeing your idea from the outside, not just your, it's good to have some ego into that, but saying how is it really gonna be seen from an outside perspective, and trying to understand the financials around that, and how applicable, because for example, I also know myself that many ideas I may have in my field, as much as is important and is broad, is not as catchy as many other fields where you can, if I have one application in cardiac surgery, in many other fields you have 100,000 applications. So clearly it's going to be way easier to find funding to create those ideas than one of my ideas. But eventually you will find some financial support or a company interested in developing yours.
You show us what you want to comment on this.
I mentioned when I was talking, when we had developed this technique that made things much safer and much faster, that the company eventually didn't go with it. They came to us to help us to want us to develop, and supported us developing the system. We wrote patents together, we licensed the system to them. The chief technology officer and the chief executive officer of the company were visiting us all the time and were very, very supportive. The problem was that it required a different level of approval, regulatory approval, to get the government to approve this technique. And the board of the company voted not to go through that procedure because it was going to be extremely costly. And so they completely abandoned it. So we had this great idea, it was clearly beneficial to patients. The most senior officers in the company were fully behind it, and yet the people who were holding the purse strings decided that it was too expensive.
Has institutions like Mars and the new one at Hamilton, where there's collaboration with CFIA and INSERC for funding for startup projects, have they been helpful here in Ontario and in Canada?
Absolutely, I think Mars is a fantastic organisation. We have a kind of mini environment in London. We have our own incubator space within the robots. We're very fortunate at being right on campus between the hospital and the medical school, and so that helps as well. We have space for startup companies to do their thing, even have some manufacturing facilities. It's nowhere near the extent of Mars, but it's doing its bit. And I think I was very skeptical 25 years ago when Mars was started up, but I see it's operating now. I was at a meeting at Mars just 2 days ago. And I've known lots of companies that have started off with space in the Mars building, and it's helped them find their feet and grow. So absolutely.
Yeah. Okay, go ahead. I would like just to comment about funding, since you mentioned it. I think the government and CHR should do more, because what you see here is the results also of many failures that you don't see here, and probably Gianluigi can tell he had 150 ideas, but one worked. And funding, it's something that CHR has to do better, because basic research is fundamental to go to this kind of process, because there is many failures before, and it's important to support also initial steps of the research that we are trying to go in translation after, but without that fundamental, it's like building a house without the pillar that support the house. So I think governments here and in Italy should do better in research funding. Gianluigi, you want to?
No, I think that that's true. Like we really need to have these opportunities first to test these ideas, and that's why having grants that are becoming more and more competitive and sometimes more and more challenging, especially when you need to prove a concept. So I think that's very important that these are continually, supported from that standpoint. That's also why obviously government agencies are key, but sometimes you have to have other ways, like having fundraising for research, which is you get people that are willing to support your research projects, and that helps you given the freedom that you have to test ideas and to eventually creating the foundation where then you can apply more successfully to grant agencies, because otherwise you don't really have anything to start. That said, I have to say that as much as I think Italy is a very strong land of creativity, that kind of financial support is definitely lacking compared to Canada. That's also one of the reasons I found that professionally this would have been an opportunity to also have access to otherwise resources, which I found many times in Europe. I would say for sure in Italy can be more challenging. So this is something we have to acknowledge. This country is helping providing us.
Luigi, so you left a home in Italy. There is someone there that you trained, and which is the best hospital that does basic surgery?
Well, no, I mean, Italy is doing great without me, and I'm just happy to go with my wife and daughter back to Italy for vacation. No, of course there are like pockets of excellence also in Italy. I'm actually, I got to say, I'm proud that I still have a very good relationship with many of my former colleagues, or maybe not so proud that I'm also getting a bit more seasoned, so that my former mates during residency now are all become as well seniors, and they send their team members to spend some time with me. So it's a way for me to still support what I receive in Italy as a training, and trying to help cross-training people from Italy, so that when they go back, they can also help contributing to continue have Italy as a very good place for healthcare.
Oh, definitely. There is another question.
Can I ask Dr. Peters a question? So my technology is, my background is in technology, so I'm just wondering if you've utilized the technology triangle, like the Waterloos, that whole sector there in your work perhaps, and maybe involve co-op students. I mean, there's so much, I think.
We have constant flow of co-op students from Waterloo, and they're absolutely delightful.
Right.
We also have very strong collaborations with Waterloo companies, particularly Northern Digital, which is the world leader in the technologies used in operating rooms for tracking instruments, that you can do it both with optical systems and with magnetic systems. And 3 of my former graduates have become, have senior positions within that company, so absolutely, Waterloo is great.
Yeah, it's not just Waterloo, there's the whole
Yeah.
triangle there.
Yeah, but Waterloo in
Yeah.
particular,
Yeah.
we
It's
really.
engineering.
Yeah.
Good to hear.
There are other questions from the floor, otherwise I will.
Yeah, just a quick question. From the images, when you get the images and actually when the person is an OR, what is the time frame you're talking?
Sorry, when you get
The
into
images, we were talking about taking images, whether it's an cardiac MRI or ultrasound. So, and by the time, if they need a surgery, what are we talking, weeks, months?
so, but you're talking about planning the work?
Yes,
The planning?
yes.
Well, that's something that likely is not done while in the OR, so.
No, but I mean, is it weeks before, or, when you start taking your first, let's say, cardiac MRI, and then you end up in an OR, are we talking weeks, or months, or because of the wait time?
Oh, so that's more clinical. I thought it was about
Yeah.
processing images.
No.
So,
No.
well, unfortunately, as you know, the wait list is a big pain
Are we
here.
talking months or year?
Well, at least I can say for the heart, it's unlikely that it's going to take a year because unfortunately you may not be alive.
Yes.
We definitely are trying to come down, because of the issues post-COVID and even
Yeah.
healthcare resources. We have seen sometimes going up to 6 months, but now we are progressively getting faster. So I would say that on average, we could be around a few months, like 2 or 3 months, which is not too bad. Obviously, if you're urgent, your surgery is not going to be delayed,
Yeah.
but it's going to affect somebody else.
Yeah.
So that's the problem. So for sure, wait list is an issue in Canada.
Okay, thank you.
Any other final questions? Yes.
Is there any effort to use stem cell research to grow a ventricle rather than use it for a patient who has a damaged ventricle or chamber, rather than using animal equivalents or artificial
I will just start, and after I will pass the microphone. I think that stem cells are around for 30 years now, kind of. And I know we are all excited about stem cells, but it's not a solution for everything, as you could see from today. And creating this in the lab, I think they are already doing a great job reducing animal facility work, because we know as a researcher that we kill many animals by the end of the year, and doing this simulation that Dr. Peters showed, it's already doing the maximum that we can. I personally don't think this will speed up the process, but instead improving what Dr. Peters and Dr. Bisleri are doing in implementing AI in their models and machine learning and algorithms to improve and making better tools can be the solution. I personally don't think that stem cell could do the trick in this specific field, but I think Dr. Bisleri and Dr. Peters can add more.
So I actually been involved in my past life also with stem cells early in my career, and I got to say there was a lot of excitement, and I'm literally talking about 20 years ago, and we were, oh my God, we were taking cells from, just to give you an idea, from the muscle here, let's say from the arm, and then just reprogramming the cells and being able to get a cell that was behaving like a heart cell, but that got nowhere. To rebuild an entire heart, for example, and ventricle is an effort of a complexity that may be eventually possible, because again, medicine is really challenging many things and is rapidly changing, but I can tell you that honestly in the last 20 years this has not gone anywhere in the ventricle. To give you something in theory simpler, I was talking about valves and the fact that you could say, okay, rather than using an animal heart, trying to use something with the patient own many cells, having a scaffold where you can then put a layer of cells so that it's like your own valve that you artificially is not still doable. And if it's going to be doable, like what's going to be the time frame which is going to be taken before you realize that, how long it's going to last, how long it's going to cost. Like there are so many challenges in that I personally agree a lot with Emilia. It's very exciting to hear that. I can only tell you that the issue also with stem cells that we tend not to consider is that how do you control what they're going to become? Because one of the issues, for example, 20 years ago there was a lot of trials trying to even inject stem cells like in the heart, and then they were turning into cancer because you don't have, if they are too already committed to become a certain cell, they don't settle in the area because they are not recognized as their own cells. If they are two stem cells, they may actually be uncontrollable and become cancer. So everything is possible, but unfortunately right now, I think very far from wide clinical application.
How could you control stem cell development so that you take a cell
It's very
be able to stimulate that cell in order to grow to become a ventricle or a heart valve?
Well, it's very difficult. If we will know that,
why I don't understand why is it so difficult?
because it's very difficult. Again, that's why.
Not providing me with any explanation.
Well, I'm going to give you an explanation why we still have cancer. Because if that would be that easy, we would have a solution to control cancer. And we don't have a solution because unfortunately, cells respond to the environment around them, and sometimes they become unresponsive. And unfortunately, controlling all the genes that are activating those cells and what their behavior is going to be is not as easy as taking a cell and putting in a certain environment and predicting what the behavior. It's a very complicated biology. So.
Right. Well, you would, I guess, initially conduct the experiments within controlled laboratory conditions, so you would be able to identify the parameters that are involved in this cell.
Unfortunately, when you do then in animals or in humans, then it doesn't work because there are many factors that you're not accounting when you are doing an experiment in just some cell cultures, and that's a problem between in vitro and in vivo. So.
I will close the Q&A session, and thank you for your attention. And to the speaker, I will pass the microphone to you.
Thank you very much, Dr. Luigi, Gianluigi, and Dr. Terry Peters. This is very illuminating, this fascinating, and I'm glad that usually we talk about literature here, cinema, music, but such a fresh discussion is absolutely needed. So thank you for your participation.
Thank you.
Thank you.